Good afternoon. My name is Elise Day. I'm Associate Professor of Urology at Massachusetts General Hospital in Boston, and I'm privileged to introduce Dr. Charles Argoff, Professor of Neurology at Albany Medical Center. Today we're going to be talking about pelvic pain, and the goal of this talk is to provide the differential diagnosis for pelvic pain in all genders. In other words, what causes pelvic pain? The ICS has a number of resources on pelvic pain. This includes standardization documents as well as videos of prior workshops, including Charles Argoff at the ICS in Gothenburg. So the 10 pearls we'll go through today include a general approach to patients with pelvic pain, and then the following etiologies: gynecologic, genitourinary, gastrointestinal, vascular, musculoskeletal, neurological, including central nervous system, peripheral entrapment, peripheral neuropathy, the difference of pain confined to the pelvis versus that associated with systemic syndromes, rheumatologic, and psychologically amplified pain associated with central sensitization. Charles has the following disclosures, and I have none. So pearl number 1 is the general approach to pelvic pain. It's important to understand that if we don't know what to do, we can have different reactions when we encounter a patient with any diagnosis. And we can choose to problem solve, avoid the problem, or sometimes it might be natural to attribute negative characteristics to the patient. So when interviewing a patient with pelvic pain, proven communication strategies include giving the person 18 seconds to tell their story without interrupting. This will give the patient the impression that you spent an additional 15 minutes with them in that you're really listening. I'll often let the story go on for longer than 18 seconds because the story itself reveals the contributors and in many cases gives me the diagnosis. Some people are more organized than others, and so I interview accordingly. Body language can be important to set the tone, including sitting to speak with the person, removing barriers, making eye contact, avoiding blocking the door. And then it's important to practice trauma-informed care, preserving locus of control and giving the person control over the circumstances and what can be a difficult interaction. So for any provider in any field, the basic steps of addressing pelvic pain includes validating that the pain has causes and treatments, assuring that we will likely provide help, even if we is our associates, providing patient resources, using the initial conservative steps, which are normally employed, and then adding testing and trials, which derive from the history and prior treatments the person has tried. Sometimes we go directly to extensive imaging if the story is strong enough. And interprofessional collaboration can be extremely helpful, if not indispensable. So what resources do we have? Well, I like to use something called a treatment map, in which I have the patient fill out the medications that they've tried by category with their response, why or why not they're still on the medications, procedures and surgeries tried by category with response, diagnostics, current providers, diagnosis of running diagnosis, and plan. As we know, these patients can become very complicated, and keeping track of what we've done can be overwhelming in a clinic session. So I ask my patients to bring this document with them so we can both benefit from it. Other resources, the Chronic Pain Working Group of the International Continence Society, in association with other societies, provided a very nice document exploring pain characteristics as well as domains of pain, local versus decentralized pain, and looking for comorbid conditions. The American Urological Association guidelines include guidelines for interstitial cystitis, as well as recurrent uncomplicated urinary tract infections. The European Association of Urology has a very helpful document on chronic pelvic pain, describing the syndromes that are present when no cause has been identified. And this is a nice document on female pelvic pain, exploring the differential diagnosis. Today we present our own expanded differential diagnosis for pelvic pain. There have been about 60 authors contributing to this list. And in addition, this also includes male pelvic pain. So pearl number 2, chronic pelvic pain of gynecologic etiology. So chronic gynecologic pain, to be distinguished from acute pain, includes endometriosis, which is cyclic pain associated with extrauterine endometrial implants impacting 5% of women. It should be suspected in severe pain with menses, painful intercourse, bowel movement, and of a cyclic nature. It's diagnosed sometimes on imaging, but more accurately on laparoscopy, and typically is treated with NSAIDs, hormones, or surgery. Adenomyosis is an endometriosis variant in which the implants are in the muscle wall of the uterus. There's cyclic pain with bleeding into the uterine wall, which feels like a bruise. Treatment is hormonal, including IUD or hysterectomy. Uterine fibroids are not a common cause of pain, and they are a common finding. Patients can have pain from the mass effect when they're large, from the uterus contracting around the fibroid. They can experience heavy menses if it's submucosal, or twist on a stalk if the fibroid is pedunculated. Vaginal septum or Gardner's duct cyst can cause pain during intercourse or even a chronic appendicitis. Ovarian pain can be identified in Mittelschmerz, which is ovulatory pain alternating sides. These are functional cysts and are treated with hormones, for example, oral contraceptives. There can be an ovarian pelvic venous abnormality we'll explore later. Ovarian cysts, torsion, or other growths can be diagnosed by ultrasound, and typically they'll be either observed or treated surgically. Infection, including pelvic inflammatory disease, can cause chronic pelvic pain, and resulting scarring can also. Vulvar pain is common. It can be due to vulvar exposures or infection, atrophy, low testosterone, dermatologic conditions, for example, lichen sclerosis, neuropathy, as Charles will discuss later, friction from sexual activity, clothing, or activities. And clitoral pain is something patients are reticent to discuss, but this can be present from a straddle injury, entrapped hair or schmegma, atrophy, or a nerve condition such as small fiber polyneuropathy. On physical examination, it's important to perform a Q-tip touch sensitivity test, exploring the pain points of the vulva, specifically the Skene's glands and the vestibular glands, the posterior fourchette, and also the minor vestibular glands. Examination of the pelvic floor muscles is very important in both genders, particularly in females, and pain along the levator muscles, the obturator muscle, the coccygeus, or even the piriformis can be revealing of pelvic floor muscle dysfunction. High-tone pelvic floor muscle dysfunction occurs in up to 87% of women with chronic pelvic pain. In contrast, it's present in only 13% of women on screening examinations. This state of overactive contraction can result in decreased flow rates, obstructed defecation, dyspareunia, pain, and resultant anxiety, and it can even result in pudendal nerve entrapment. So you get an idea of how the organs cross over when we're evaluating patients with chronic pelvic pain. Physical examination can reveal prolapse. It's important to look for it. This can most commonly would cause more of an aching pain throughout the day, particularly if the bladder is kinked and not emptying, and the pain would be improved during rest. If someone's had prior surgery, you may identify mesh erosion, or there may be the potential for nerve entrapment, as Charles will discuss. In some regions of the world, female genital mutilation or cutting is common, and in these cases, you can find neuromas, scarring, and urinary stasis resulting in urinary tract infections, urethral stenosis, and all of the above can also lead to pelvic floor muscle dysfunction. So treatment of vulvodynia involves a multidisciplinary approach. Infection, atrophy, neoplasm will be treated. Physical therapy can be important for releasing the pelvic floor muscle dysfunction, which will improve circulation to the vulva. behavioral therapy, for example, avoiding vulvar irritants, certain medications, for example, tricyclics or anti-seizure agents like gabapentin, botulinum toxin injection off-label, interventional pain techniques, including local injections, and very rarely surgery is offered and should be performed by consensus and in experienced hands. Here's a list of vulvar exposures, which you can refer back to. The main points are toilet papers and soaps, douching, and certain lubricants can be more or less favorable. Pearl number 3, chronic pelvic pain of urologic etiology. So the urologic differential includes things such as pelvic floor dystonia, again, bladder pain, interstitial cystitis or bladder pain syndrome, urethral diverticulum. Urethral pain is very tricky. It can be due to vulvovaginal atrophy, urethral caruncle, friction, a tight external or internal sphincter with turbulence or a urethral stricture, a Skene's gland cyst or urethral diverticulum, a stone at the ureterovesical junction can be referred to the urethra, tumor, infection. Ureaplasma and mycoplasma have to be sought separately from the standard urine culture, or sexually transmitted infection. Recurrent urinary tract infections can obviously cause urethral pain, but when the cultures are negative, I start to be more suspicious of something such as small fiber polyneuropathy or another systemic sensitivity. This is a picture of a urethral diverticulum on MRI. This patient could report post-void dribbling, pyuria, urinary tract infections, dyspareunia. There can be appreciation of a cystic mass on physical exam, but that's not a sensitive test. If it's suspected, one can try milking the anterior vaginal wall, looking for expressible fluid and pus. Certain imaging modalities, such as voiding cystourethrogram, can demonstrate the diverticulum, so it should be looked for during fluoroscopic urodynamics, but MRI is the most sensitive modality. One caveat is that prior bulking agents may be inappropriately read as diverticuli. Ureteric pain. This can be caused by stone, and it can be chronic, meeting the diagnosis for chronic pelvic pain, ureterocele, endometriosis or other scarring, and iliopsoas pain will mimic flank pain and ureteric pain. It's been shown that hyperalgesia can persist in muscles for months to years after a stone has passed, and women compared to men have been shown to have a greater density of nerves in the very last 2 centimeters of the ureter as it enters the bladder, which can potentiate pelvic pain. Treatment is aided by alpha blockers, NSAIDs, or if a structural issue is present, surgery. In patients who have refractory overactive bladder and irritation, cystoscopy is indicated if conservative measures are unsuccessful. This is a picture of carcinoma in situ. So we have the benefit with respect to interstitial cystitis of the AUA guideline. This guideline clarifies the diagnosis of interstitial cystitis and bladder pain syndrome, which has changed over the years. First-line treatments include general relaxation and patient education. Second-line treatments, manual physical therapy techniques, some oral agents such as amitriptyline, and pain management, as well as intravesical therapy. Third-line treatments include cystoscopy under anesthesia with hydrodistension and pain management. Here we have an image of glomerulations and a Hunner's lesion, and fulguration of the Hunner's lesion and hydrodistension are still recommended as third-line therapy. Fourth-line therapy, although this is not an FDA-approved application, this is off-label use of botulinum toxin, can be helpful in pain as well as the urgency and frequency associated with IC. The patient should be prepared for intermittent catheterization, so if urethral pain is a significant issue, this might be a bad step to take. Fourth-line therapy also includes sacral neuromodulation. Again, this is off-label use of sacral neuromodulation. Fifth-line therapy includes cyclosporin A and pain management. And sixth line is formal surgical intervention. It should be noted that augmentation cystoplasty has marginal results in IC. Also, if diversion is going to be attempted, a cystectomy should be included to avoid complications of pyocystis and also continued pain from the defunctionalized bladder. It's also been shown to help more in classic interstitial cystitis with Hunner's lesion versus non-ulcer bladder pain syndrome. And due to the finality of this therapy, it should be performed after consensus is reached among providers that this is the next step. Bladder outlet obstruction can lead to chronic pelvic pain, including not only cystocele and prostatic obstruction, but also bladder neck obstruction and other more neurological contributors. Male organ pain includes prostatitis and epididymitis. It's been shown that transurethral resection in chronic and relapsing bacterial inflammation, especially in the setting of stones, is successful in 30 to 70% of patients. In bladder outlet obstruction, alpha blocker and outlet procedures can be helpful. Chronic testis pain is present in fewer than 1% of men. This can be due to a mass, intermittent torsion, or nerve pain. For the nerve pain, treatment will include antibiotics, anti-inflammatories, medications such as gabapentin, physical therapy, nerve blocks, and ultimately surgery. Pain with ejaculation is present in 1 to 10% of men. This can be related to pelvic floor muscle dysfunction, but also structural issues such as ejaculatory duct or vas deferens obstruction. It should be suspected if there's pain with or following ejaculation, especially if there's a low semen volume. Diagnosis is by transrectal ultrasound showing dilation of the ejaculatory ducts. Peyronie's disease, scarring of the tunica, can be treated initially with medications or injection of the scar tissue with collagenase Clostridium histolyticum, or if the angle is severe enough and prevents function and causes enough pain with the angle, surgery can be employed. Sexually transmitted infection is another obvious cause of chronic pain in men. Pearl number 4, chronic pelvic pain of colovesical etiology. So there are many causes, including diverticular disease, where the diverticulitis itself or resultant stricture or fistula can cause pain. Appendicitis, hernia adhesions can be appreciated in the pelvis. Inflammatory bowel disease, such as Crohn's or ulcerative colitis. Irritable bowel syndrome, constipation, obstructed defecation, levator ani syndrome again, and proctalgia fugax, which is severe episodic pain associated with the anal sphincter or levator complex in spasm. Anal pain can be caused by fissure, abscess, warts, Paget's disease, hemorrhoids, rectal prolapse, and of course tumor, anal or rectal cancer can cause pelvic pain. So what symptoms suggest a GI etiology? Pain that's worsened or relieved by bowel movement, associated with infrequent bowel movements, for example, constipation, pain that returns with eating, pain associated with specific foods, for example, dairy, intestinal gas or bloating, blood in the stool, feculent urine, recurrent urinary tract infection, progressive worsening with fever or weight loss. So with diverticulitis, the pain is usually left lower quadrant and more acute, constant, and present for several days, but it could become chronic and present as such. Acute diverticulitis leads to constipation, diarrhea, and more rarely hematochezia. And importantly, in 10 to 15% of patients, we'll see urinary urgency, frequency, or dysuria due to irritation of the bladder from an inflamed sigmoid colon transmurally. Here's a photo of a colovesical fistula, which could lead to recurrent urinary tract infections and pelvic pain as the only presenting symptoms. And then there are functional disorders of the GI tract. So once we've ruled out inflammatory bowel disease, celiac disease, cancers, and severe constipation, we can think more about GI motility disorders associated with autonomic neuropathy, again, to be addressed in Charles's talk. Or
I just want to interrupt for 1 second. Elise, Dr. Day, you mentioned several times a number of conditions that we're going to come back to as being seen in people with different types of neuropathy. So you start
Yes.
wondering, are we maybe looking at this a little bit less broadly than we should, as opposed to being an anatomical area that's involved? Is it part of a more global process that maybe
Yes.
we can all partner with?
It's a real web, and I think that's probably how we developed such a close relationship over the years, is we share so many patients due to the overlap. Thanks.
Sure.
So in irritable bowel syndrome, this is tied more to the enteric nervous system. The patient can complain of crampy pain in lower abdomen or pelvis and bloating, pain with defecation, diarrhea, constipation, or both, change in stool frequency. And typically it's managed with food trigger avoidance, including dairy, gluten, fermentables, depending on what the triggers are. And we often find it can be associated with other hypersensitivity disorders, for example, migraine, fibromyalgia, interstitial cystitis, and in those cases, gabapentin and certain antidepressants that are effective for pain can be employed. Hemorrhoids, treatment for hemorrhoids is to avoid constipation to interrupt the cycle of straining, hydration, increase fiber intake, toilet positioning with the feet on a stool or more in a squat position, straightening the angle between the rectum and the anus, and pelvic floor physical therapy. Sitz baths can be useful for hemorrhoids, topical preparations with suppositories with hydrocortisone, and in refractory cases, surgery, including ligation, cauterization, sclerotherapy, excision, or mucopexy. Anal skin irritation or dermatitis can be very bothersome to patients. Typically here, irritants, including moisture or feces and excessive cleansing, can lead to the irritation. It can present within hours after the exposure, associated with erosion, erythema, and scaling of the surface. The patient can complain of burning and itching. Also, a fungal infection can be overlain on the irritation with satellite lesions. Treatment includes avoidance of irritants, bulking agents for easier to control stool so the area is cleaner, pH balanced cleanser, cleansing and patting dry with a soft cloth after every bowel movement, followed by skin barrier products such as zinc oxide, petroleum, and dimethicone. And the skin barrier can be preceded with an antifungal agent if candidiasis is present. Anal fissure is an actual tearing of the anal lining. The patient experiences sharp anal pain worsened with bowel movements described as razor blades. They can experience minor bleeding, discharge, burning, and itching. A gentle exam with cotton swabs can identify the lesion. It's often associated with a skin tag, and due to the pain, exam under anesthesia may be necessary. It's usually caused by baseline high anal sphincter tone. It's exacerbated by chronic constipation and anal trauma. Treatment, again, includes avoiding constipation, topical calcium channel blockers and glyceryl nitrate, or sometimes chemodenervation of the muscle. And lastly, a fissurectomy or lateral internal sphincterotomy may be required. Pearl number 5, chronic pelvic pain of vascular etiology. So pelvic venous disorders include pelvic congestion secondary to poorly functioning valves along the gonadal veins, or nutcracker syndrome and May-Turner syndrome or variants thereof. So pelvic venous congestion syndrome, the retrograde flow and the weak vein, the symptoms can be vague due to the dilated pelvic varices. They're more common in multiparous premenopausal women. They may complain of a dull, throbbing, and achy pain in the vulva. The morning is better, and they're worse with standing. The pain can be present throughout the month, but worse with menstrual periods. Dyspareunia, bladder irritability, GI symptoms, and low back pain may be present. On physical exam, ovarian point tenderness on examination with a history of a postcoital ache is 94% sensitive and 77% specific for PCS. Also of note, 33% of women with PCS have vulvar varicosities, hemorrhoids, varicosities of the perineum, vulva, or buttocks. 90% have lower extremity varicosities. However, only 5% of those with lower extremity varicosities have pelvic congestion syndrome. External venous compression can result from nutcracker syndrome, which is compression of the left renal vein between the aorta and the SMA. And also May-Turner syndrome, which is compression of the left common iliac vein by the left common iliac artery. So diagnosis is by duplex ultrasound, CAT scan or MR venogram, intravascular venography or ultrasound. And treatment is in the incontinent valves is associated with anti-estrogen medications, but this is more of a temporary fix. A hysterectomy or oophorectomy can treat the pain in the target organ, but it doesn't treat the etiology, and bleeding complications can be present. Endovascular techniques are available. There's sclerotherapy for congestion syndrome, the valves, and with improvement in 68 to 100% of women. And for nutcracker syndrome, surgery is favored over stents because of the migration potential. The data is that 87% of patients improved after a mean follow-up of 37 months postoperatively. In May-Turner syndrome, treatment is more by angioplasty and stents before any attempts at embolization. And in these patients, after the stents, 80% reported pain resolution 1 year after the procedure. Referral number 6, chronic pelvic pain associated with musculoskeletal etiology. So musculoskeletal pain is associated with a high tone iliopsoas or levator complex, trauma to the bony pelvis or hips, inflammation of the bone, for example, osteitis or even osteomyelitis, pelvic girdle or ligament pain, for example, after pregnancy, or myopathy, for example, a weakness after a stroke can lead to stresses elsewhere. So the internal pelvic floor muscle exam is easily performed in both men and women as part of a routine pelvic or digital rectal examination. And the puborectalis, the iliococcygeus, and the pubococcygeus can be palpated in combination with the obturator muscle, the coccygeus muscle, and the piriformis muscle is more easily palpated from posterior. Patients can also have associated abdominal wall and lumbopelvic complex high tone muscles. The pelvic floor muscle pain is myalgia on palpation. Trigger points can be identified where the pain is worse and reproduces other pain. And pelvic floor muscle myofascial pain includes also the surrounding connective tissue. So a simple way to do this exam or to know what you're looking for is the pelvic floor muscle overactivity or firmness manual examination. The hand in the open position, the thenar eminence feels normal. With the first digit touching the second digit, that is moderate hypertonicity. And the first digit touching the fifth digit, this is more of a severe hypertonicity as palpated in the pelvic floor muscles. So the treatment for this is a full ergonomic assessment and then targeting the pelvic floor muscles, down training. This will decrease the crosstalk along the sacral nerves, and these sacral nerves have been shown to have a great deal of crosstalk for cross-organ sensitization, for example, the pelvic floor muscles with the bladder or the rectum. Treatment for pelvic floor muscle dysfunction is heterogeneous. There is licensure and certification for this, well known to those in the ICS. The patient is provided education, goals are identified. There are hands-on treatments, including biofeedback with surface EMG and ultrasound imaging biofeedback. TENS units can be employed. Therapeutic ultrasound is employed by some therapists. This is thought to improve circulation, muscle relaxation, and loosening of scar. Myofascial release is what many of us think about as pelvic floor physical therapy, in which scars, muscles, and skin are stretched. Joint mobilization techniques and exercises such as stretches, yoga, aerobic exercise, and also assessment of how much impact the patient is having with their exercise. Sometimes the exercise can be too aggressive or high impact. So here's just an example of some stretches, thanks to my colleague Allison Snyder. Pelvic floor physical therapy for high tone pelvic floor muscle dysfunction has been shown to be successful in randomized trials. It's superior to global therapeutic massage for pelvic pain. equivalent to levator injections, and effective in pelvic girdle pain of pregnancy. Due to the heterogeneity of techniques as above and the heterogeneity of patient characteristics, more data and research is certainly needed in pelvic pain. Bone and joint abnormalities. So 20% of those with primary hip pathology also have posterior pelvic pain, and sometimes the pelvic pain is the primary complaint. In femoral acetabular impingement syndrome, the labrum, for example, can be impinged between the bones. Groin pain can be associated with the muscle compensation from this. And pain with external rotation, also seen in psoas dysfunction, can be found on physical exam. In order to delineate whether the pain is from the hip, an intra-articular anesthetic injection can be used. Bursitis can cause hip and pelvic pain. And also pelvic girdle pain can cause pelvic pain. So the pelvic girdle controls the load transfer between the lower and upper body. And the patient may experience sharp pain during movement or more of an aching. The sacroiliac joint can lead to complaints of stabbing or ache in the lower back or upper buttocks, and can be found on physical exam using the Faber test and the posterior pelvic pain provocation test. Pubic symphysis pain radiates to the groin or the inner thigh, and these are all often associated with pelvic floor muscle dysfunction. Pubic diastasis is present postpartum in 1 to 300 to 30,000 births. It's kind of a wide range, but certainly we do see it. This is associated with suprapubic pain, tenderness, swelling, and edema. It can radiate to the legs, hips, or backs, and it's worse with weight bearing, especially when walking and climbing stairs. Patients can awaken due to the pain. And on physical exam maneuvers, you can evoke this pain with bilateral pressure on the trochanters, or asking the patient to flex their hips with the legs in extension. Diagnosis is radiographic, involving a separation of more than 10 to 13 millimeters. Osteitis pubis is seen more commonly in young female athletes, thought to be due to microtrauma of the pubic symphysis. On physical exam, you will see a painful isometric adductor contraction. Sometimes osteomyelitis can also be associated, and treatment is with NSAIDs and sometimes antibiotics. There are rare conditions such as Scheuermann's disease as causes of pelvic pain. This is a sort of kyphosis of the lumbar spine seen in adolescents. Ergonomics are the last part of my section. These are very important to consider, especially in light of COVID with everyone working at home. If patients are driving an hour and a half to work back and forth or sitting on hard surfaces all days, these are very important considerations in the initial interview. Also with our patients with disabilities, ergonomics, myopathies, and bony issues can be of particular concern. This patient was complaining of pelvic pain. She had poor sensation of this area of her body, and she spent all of her time exclusively on her back. And on imaging, you can see the coccyx is not far from the surface. So once we started rolling her and repositioning her and getting her off that area, the pelvic pain improved. Okay, so now we have Charles Argoff with the last 3 pearls.
Okay.
I'll look to see if we have any questions yet.
So pearl number 7 is chronic pelvic pain associated with disorders of the peripheral and or central nervous system. So I'm going to do the best I can in the next 15 minutes to go through a lot of information. I, as a neurologist, hope that it's not completely foreign to you, but let's go through these concepts carefully. What's neuropathic pain? So a lot of what I will demonstrate today is really based upon our starting to understand, at least through Dr. Day's and I own work, and hopefully others as well, that there may be some common neuropathic underpinnings to why people experience complex and persistent pelvic pain. And maybe by recognizing that, we can move our understanding and treatments forward. So what's neuropathic pain? Neuropathic pain is defined as arising as a direct consequence of diseases affecting the somatosensory system. A very esteemed group led by the German Pain Research Network and Dr. Treed published the definition in Neurology in 2008. It was also proposed and accepted by the International Association for the Study of Pain's Neuropathic Pain Special Interest Group. And basically what that means is that it's pain from the nerves, spinal cord, or brain, not originating in the bones, muscles, or organs. But if you think about it for a second, there are neural elements within the bones, muscles, and organs. So it's all related. In the US, peripheral neuropathy is experienced by approximately 40 million people. If you think about neuropathies and axons as being related to diameter of wire or diameter of nerve fiber, you can, if you go into a electrical supply store, you'll see wires of different sizes, diameters, degree of insulation. And quite simplistically, we have nerves that are small in diameter, some which are heavily insulated and larger in diameter, some which are smaller and weakly insulated. And so the small fibers tend to play a major fine-tuning role and involved in temperature and pain sensation, autonomic function. The larger fibers are mostly involved in light touch, balance, position sense, and some other major functions as well. And increasingly recognized, and this is a really great reference for those of you who are looking at this and getting in, and for this is new information, increasingly recognized is a demonstration of small unmyelinated or myelinated fibers or small fiber neuropathy. This is going to be a recurrent theme throughout my presentation. So just by, we don't have a poll, but think about it. The person on the right, the visualization on the right is of a pretty arthritic looking knee. And we might say that the person who has pain is the person on the right on this slide because they have an arthritic knee. And the person the knee on the left looks much more robust and without degenerative changes. The reality is the person on the left may have more pain than the person on the right. And so it's not just a structural issue, it's, as we will see, not only a wiring issue or a neurological issue, but also one in which we may see states of inflammation. And increasingly, we're recognizing, at least in the neurology and neuroscience world, how inflammation and neuropathic issues kind of intertwined in many disorders of the nervous system, and really kind of maybe bring this into other areas as well. So the person take-home message here is we don't know which person has pain. Both may, only the person on the left, and certainly only the person on the right. Here are some just other neurological conditions that may be associated with pelvic pain. So cauda equina syndrome, this is a medical emergency. We're going to see, we see this all the time. You can see the lesion here on the MRI. And you can see that as well. You'll see urinary retention, sudden, more subacute urinary retention, bilateral lower back pain, radiating pain, leg weakness. The most common reason is a tumor or midline disc. And there are many other causes, including not necessarily a structural abnormality, but CIDP, which is chronic inflammatory demyelinating polyneuropathy, as well as sarcoidosis, which can, as we will see, is associated with a condition of small fiber neuropathy, as well as associated with granuloma formation. It can be associated with an infection as well. So it's important to recognize these clinical symptoms and signs and then look for the cause. Tethered cord, adult tethered cord versus is it a sacral tumor? We just saw somebody within the last couple of weeks who had this kind of complaint, history in the past of a carrier malformation, decompression, and we are seeing now on imaging studies syringomalia in an adult who, and so these are the symptoms to look for. And this particular tethered cord syndrome may go undiagnosed until adulthood. The other important point is that because it may involve the distal aspects of the cord, you may see both spastic signs of upper motor neuron dysfunction as well as signs of lower motor neuron dysfunction. Tarloff cysts actually are of uncertain etiology, uncertain significance, excuse me. And I think that's important. I mean, these are not a rare finding on imaging studies in the lumbar and sacral region. And I think that the jury is still out, just how surgeons will have very clear opinions about whether or not they should be removed or not. Some are in favor, some are not. And I think we still don't know to what extent. And Dr. Day, I don't know if you have an opinion about this or you want to share later, or now. In my experience, there are many different opinions about this.
I think after trying conservative measures and trying to ignore the Tarlov cysts, we have to start thinking about whether they're the source of the pain. And I have one patient who had surgery for them and worsened. So it's really a big decision to move forth with surgery.
Right, because it may not be a good outcome. Right.
Right.
So we also are concerned about peripheral pelvic nerve entrapment. So that could be a single nerve or nerve root. And the symptoms associated there would be pain, tingling, numbness, and muscle weakness within the nerve or the nerve's distribution, or if it's a nerve root, the myotome, if it's motor, or the sensory dermatome. And possible causes could include endometriosis, fibrosis, graft compression, suture, vascular or muscular entrapment, or transection. Here is just a review, and as I'm sure you're very familiar with this, of the pelvic-perineal innervation from a somatic, autonomic point of view, as well as specific peripheral nerves, including the genitophemoral nerve, which comes from L1 and L2 nerve roots, the obturator nerve, which provides adduction and other functions of the thigh and knee, important to know, and the pudendal nerve, which has a number of anatomic variations. So branches, for example, can penetrate directly through the sacrospinous ligament, and injury of this branch can lead to fecal incontinence, so it can present in different ways. And here's just an overview of a lot of information in one slide, just to remind us of how complicated things are. Okay, again, just recognize, and I think this is something that we've learned, Dr. Day and I certainly have learned, is that the more time that you can spend in your initial assessment and mapping out the pain, asking people functional questions, sensory questions, and asking them to draw a pain map, the more we can help us ourselves to understand which peripheral nerves might be involved. Just pudendal neuralgia can be associated with piriformis muscle. There are different anatomic variations where problems. The piriformis muscle is quite important because the nerve can traverse the muscle, so that muscle hypertrophy or spasm can be associated with pudendal neuralgia. I have successfully, under radiographic guidance, injected, again off-label, as was mentioned earlier, botulinum toxin into a piriformis muscle that was hypertrophied by X-ray, by CT, I could see this, to relieve a person of pudendal neuralgia. There have been some case series published about this, but it's important to realize that there may be a way of freeing the nerve through different injection techniques. The pudendal nerve is associated with sacrospinal and sacrotuberous ligaments in 42% of cases, and an Alcock's canal in 26% of cases, and at multiple levels in 17% of cases. And the more distal, the less likely the anal region will be involved. Treatment, neuromodulators can take the form of multiple types of medications. We're all generally familiar with tricyclic antidepressants, various anticonvulsants, even alpha-2 adrenergic agonists like tizanidine off-label has been used historically for many decades. In some situations, physical therapy, trigger point injections. I just mentioned an anecdote of use of botulinum toxin. Neuromodulation can be utilized, and there have been some individuals with not 100% relief, but in one prospective randomized study of surgical release, if the pain had been present for less than 6 years, almost 2/3 of people improved. If it had been, as might be expected there, for longer amount of time, fewer people improved. And here's just a review. Colleagues of ours who are very familiar with neuromodulation. These are neuromodulation, very experienced people, showing that that neuromodulation for pelvic visceral pain can be successful and may be considered as part of a treatment armamentarium. So pearl number 8, is the pain confined to the pelvis versus a systemic or multifocal condition? So I cannot underestimate, sorry, the importance of really getting a good handle of what, it's so important to listen to what the person in front of us is experiencing and where he or she is experiencing the pain, and if possible, using a pain drawing like this, and then try to understand what that means before making a diagnosis, because this really will tell us a lot about the extent of the pain. Dr. Day already used several times the idea of sensitization, and the more sensitized the process is, the more out of the territory of a single nerve or nerve root or set or plexus you're going to see things. And so it's important to see what the person, of course, it's also important to see if a person shades in the entire front and back of this diagram and says, and throws up a white flag for surrendering, because that person is telling us, in addition to into some types of pain, they're telling us about other anguish as well that we need to take into consideration. So a brief further review of the idea of neuropathies. Large fiber neuropathies are associated with larger, more heavily myelinated fibers. They travel faster to the brain when activated. Think of what we do when we're in pain. If we were to slam our fingers in a car door, we might start squeezing or rubbing that area because we are trying to activate, consciously or otherwise, these large fibers to beat the pain, which is a small fiber function, to the brain. And so large fibers travel faster than small fibers. Small fibers are responsible for pain, different types of pain, thermal sensation, and we on examination, the typical examination we do in an office setting, even neurologists, is mostly large fiber testing. We're going to test proprioception, vibration, motor skills, reflexes. These are all balanced. These are usually large fiber changes. To do and test small fiber function, we may have to do more sophisticated testing, such as quantitative sensory testing. Nerve biopsies are done less often, but more and more, if we're thinking small fiber, we're doing skin biopsies, because a reduction in intraepidermal nerve fiber density, as well as a reduction in sweat glands in the skin, has been shown to be both specific and sensitive, or relatively specific and sensitive, for small fiber changes. Now, we commonly, we all globally use electrophysiological testing, EMG and nerve conduction velocity tests, and we have probably seen that in somebody with terrible pain, and they come back normal. That's in part because we are not evaluating for large fiber changes with that test. It's a commonly done test. It has its utility, but when it's normal in somebody with severe symptoms, it means that we've done what we can to evaluate for large fiber neuropathy and not small fiber neuropathy. So this is an important paper, not because Dr. Day and I are authors on it, but because really in taking care of people with complex pelvic pain, we had this thought together that what if there was an underlying neurogenic, neurologic, neuropathic kind of etiology that brought, that it wasn't just the pelvis, but there were other commonalities that would help us to understand systemically. And so there, in the real world, 53 out of about 100,000 people, 53 out of about 100,000 people experience small fiber neuropathy. It's based upon a Dutch study. We consecutively offered people who were evaluated at our pelvic health center the opportunity to undergo a skin biopsy. And we found that 64, just shy of 2/3 of the 39 patients who underwent skin biopsies with complex pelvic pain had a positive biopsy for small fiber neuropathy. Of interest, in keeping with this idea of maybe it's not just the pelvis only that's involved, 46% had GERD, 38% had migraine, 33% had IBS, 33% had lower back pain, 38% had fibromyalgia, 15% endometriosis, 18% interstitial cystitis, other chronic pain syndromes 36%, and vulvodynia 5%. And of course, a person could have more than one. And so this was illuminating to us.
And Charles,
yeah.
These patients with complex pelvic pain, we define them as those who were refractory to the standard interventions or those who had multifocal pain at presentation. For example, GERD, pelvic pain, migraine.
And so that this is quite interesting. So I'm going to concentrate a little bit of time on what small fiber neuropathy is. It is, again, an abnormality affecting the small myelinated adelta or unmyelinated C fibers. And these can also include small somatic as well as autonomic fibers. And so now increasingly we're seeing people who have paroxysmal orthostatic tachycardia syndrome and chronic pain. And it's really been a fascinating experience. Enteric function is also subserved by small fibers. I mentioned thermal perception is we talked about large fibers earlier and what they and then the role that they play in nerve function. Most small fiber neuropathies, according to older literature, occur in a length-dependent fashion. So first the stocking distribution changes and then later glove. But, and it's not rare anymore, we're seeing more and more, because we're testing more and more, non-length dependent small fiber neuropathies, which is interesting because perhaps the first symptom that a person may experience is pelvic pain. So we're also seeing face, truncal, proximal limbs, or other more localized areas can be involved first. And we don't understand, as you'll see, there are many different disorders associated with small fiber neuropathy, the exact mechanism of the injury. It can, in a condition like diabetic neuropathy, which can present first as a small fiber neuropathy, it can present to large fibers. I apologize, it's not 55 out of 100,000, it's 12 out of 100,000. So that's even more startling that in our population that we study, we just asked the question, 64% of people. That's much more than this Dutch study. Children can also experience small fiber neuropathy. Muscle cramps can be a presenting complaint. Here, the take-home message from this information is that small fiber polyneuropathy is clearly associated with a big impact on quality of life, including healthcare costs. So the next couple of slides are going to be literally a laundry list of some of the disorders that are associated with small fiber neuropathy. Probably the most common known cause is some degree of impaired glucose tolerance, including diabetes. Sarcoidosis is also thyroid dysfunction, HIV, B12, B12 deficiency, vitamin B1 deficiency, various chemotherapeutic agents. Celiac disease. Dr. Day, you mentioned celiac disease earlier with other conditions. How many of those patients might also have small fiber neuropathy, as well as a structural abnormality that would render that person more sensitive to that structural abnormality, perhaps because they have multiple problems. Sjogren's syndrome, paraneoplastic syndromes, rheumatoid arthritis. We'll come back to that point. Idiopathic up to 50%. Oh, there's more here. You can see all these different conditions that we commonly see. One of the most fascinating stories has been the EDS story. There have been several publications from Italian investigators several years ago, and increasing recognition that EDS, as many of you have seen people with EDS, they often experience chronic pain in multiple sites, perhaps including their pelvis, and they are often thought of being drug seeking because they're asking for help. And various groups, international groups, including our group, have now shown that small fiber neuropathy is highly prevalent in people with EDS. I saw a person yesterday afternoon whose mother for years had issues with pain and gastroparesis. And she herself is now in her 40s, the person I was seeing, and is wondering what's wrong with her. And we are about to schedule a skin biopsy because I think she has a hereditary form. We also published previously, a group that I work with here at Albany Med, that patients with central post-stroke pain had findings consistent with small fiber neuropathy. Does that render that group, we don't know why they had that. So I think, was it a consequence of the stroke or was it preceding? And is that why they had central post-stroke pain? These are really interesting questions to consider, including how it relates to pelvic and urogynecological pain. And here are many other conditions, so a lot to consider. Sodium channel abnormalities. Sodium channels are really important for nerve conduction. Steve Waxman and his group, as well as others, David Bennett is a British investigator, have demonstrated sodium channel mutations may result in gain of function mutations and facilitation of pain transmission. And the opposite is true of sodium channel mutations, where the there's a loss of function, and that may be that underlies congenital insensitivity in pain. And so it's very interesting because many new therapeutics that are being developed for small fiber neuropathy are targeting the sodium channel. Symptoms really vary. Usually it's a vague sensory disturbance, which maybe makes it difficult to fully assess. And so it's important to really ask. Burning pain, socks or bed sheets may be painful. Autonomic symptoms may be present, including changes in urinary frequency, erectile dysfunction, many of the things that we just heard previously. Dysautonomia in small fiber neuropathy is very common and should be considered and looked to. I mentioned POTS earlier for cardiovascular dysfunction. People will have unexplained dizziness. In fact, people will think of it in the general provider world or neurology world as the bane of their existence. They don't get a good answer. Why are people dizzy? Maybe we need to start looking at the combination, the collection of symptoms. This is what an epidermal nerve fiber density would look like. Normal, you can see the density on the panel A, and B is an 18-year-old person with widespread pain and a much lower density of axons. This is work done by Anne-Louise Oaklander and her colleague Max Klein. They are also at Mass General Hospital. And you can see the specificities and sensitivities. EMG is limited. I mentioned that earlier, does not assess small fibers. So quantitative sensory testing and skin biopsy are the way to go. Skin biopsy is very easy to do. And it's a 3mm skin punch biopsy. For anyone who is interested in doing it after this webinar, they can contact us and we can explain how to do that. Corneal confocal microscopy is now increasingly being done, and some investigators believe it has the same sensitivity or specificity as skin biopsy and is not invasive. Many different medical conditions, as mentioned earlier, can be associated with small fiber neuropathy. So please consider a comprehensive assessment from a laboratory testing point of view to look for these abnormalities, and including sodium channel genetic testing in the extent that since it is associated, mutations are associated with small fiber neuropathy. Treatment, treat the treatable. We have identified people who didn't know they had diabetes. We treated diabetes. Gabapentin, tramadol, other neuromodulating agents might be helpful. And here's just recommendations in the past from different societies regarding different neuropathic pain treatments. I want to emphasize that opioids should be used second or third line almost always. And we have to use them very cautiously. And there are new developments coming out soon, hopefully, because there's many investigations for new treatments. In instances where small fiber neuropathy, including that associated with pelvic pain, is believed to be associated with an autoimmune process, there is now increasing some evidence that IVIG, especially in sarcoidosis, may be associated with intravenous gamma globulin with improvement not only in the pain but also in dysautonomia. This is a treatment with its own set of concerns and an expense, and so it has to be used wisely. But it can be used when conventional treatments do not work. There is data for Sjogren's syndrome as well as juvenile onset unexplained widespread pain, and another group of people with small fiber neuropathy who had dysautonomia. This is again another. Another study in which people had apparent autoimmune small fiber neuropathy. Again, we have used this in people successfully who had complex pelvic pain and small fiber neuropathy, and have helped them pain-wise and functionally. Very briefly, when we mentioned earlier, Dr. Dave mentioned earlier, fibromyalgia being very common, approximately across the board. If you look at all studies, approximately in this study, 41% of people, but overall 50% of people who have fibromyalgia in multiple studies, if you put them all together, about 50% of people who are biopsied with meeting criteria for fibromyalgia have findings consistent with small fiber neuropathy. And so that adds to the understanding that this condition or that small fiber neuropathy changes may underlie many different widespread pain conditions. Rheumatologic disorders, pearl number 9. We just want to remind ourselves that multiple rheumatologic disorders exist that can be associated with multi-articular, multifocal, multiple locations of chronic pain. When you might suspect rheumatologic disease, Remember that joints, muscles, ligaments, and tendons are affected, that are affected by rheumatologic disease are present throughout the body. So symptoms include fever, weight loss, and fatigue. Localized signs of inflammation can occur in any body part, and rheumatologic disease can present as pelvic pain when the joints, musculature, and other components of the pelvis are involved. In the context of pelvic pain, these are areas, symptoms that differentiate rheumatologic disease from other conditions include pain that occurs at night, that alternates between the buttock muscles, improves with activity during the day, and is relieved with NSAIDs. Morning pelvic stiffness that lasts more than 1 hour also suggests rheumatologic disease. And as I mentioned in another slide, there are common neurological disease, rheumatologic diseases to consider, such as osteoarthritis, rheumatoid arthritis, lupus, Sjogren's syndrome, scleroderma, etc. And I'm going to kind of wind down with our pearl number 10. Psychological does not equal sensitization, but many people think of central sensitization as may characterize their patient as having psychological pain, but central sensitization relates to pain that is maintained by the central nervous system without a clear signal from the periphery. And so this actually occurs perhaps because of an injury to the peripheral nervous system that persists in its ongoing pain, perhaps due to an injury such as in central post-stroke pain to the central nervous system, but it's really a bad plasticity of the central nervous system. It's a plasticity of the central nervous system. Think about this for a second. I mentioned earlier that if you rub an area that hurts normally after injuring it, it feels better. That's normal. But if an area like that gets injured, the plasticity that it may occur following results in when you rub that area, it actually hurts. That's called allodynia, or touching an area that hurts. That means that things have changed. Things have, the plasticity associated with the recovery from an injury has changed so that now the central nervous system, upon receiving a signal, doesn't dampen the pain, it augments the pain. In fact, the pain may be more painful than usual or hyperalgesic. So a good example might be post-surgical pain. It's normal to experience pain at the site of surgery until the wound's completely healed. But what about in post-thoracotomy pain or post-mastectomy pain or other post-surgical pain syndromes where the wound and the pain and the inflammation has now been imprinted on the central nervous system. And so now the pain comes independent of the peripheral nervous system. That's what's really meant by central sensitization. And many of us have seen people who look perfectly fine, but yet they have this process in them. And here's a very interesting and nice schematic to kind of come back to about causes and how peripheral sensitization can continue to drive this. Peripheral factors can continue to drive this. And there are many predisposing factors we won't get into more detail today. But if central sensitization occurs, that is a very different set of conditions than a simple peripheral nerve injury. So it's important to recognize. And here's an example of that simple, that's a normal kind of reaction to heat. But what if something that isn't hot now causes pain? Okay. Certainly the anguish that's associated with central sensation can be quite bad. So again, central sensation is really associated with chronic pain in which there are changes in the central nervous system. We have shown that. There may be abnormal afferent activity and also abnormal efferent activity. And if there are behavioral changes, those may be also associated with changes in the central nervous system. And doing brain map, the brain actually, instead of inhibiting circuitry, expands itself. And instead of doing what it's supposed to do, which is to limit things, it does not. And that's where using cognitive behavioral approaches to help retrain the brain to treat the pain can be super effective. And this is if central sensitization is neuroplasticity gone awry, we can then still use neuroplasticity in our treatment armamentarium to help correct that or modify that. So in conclusion, patients with pelvic pain can be effectively helped. There are many different causes and very interesting developments. Caring for these people is often straightforward, especially early in their course, but it can be complicated. And referral systems do exist for more complex patients. And the first thing is really to be open to evaluating these complex individuals. So here are our 10 pearls for the differential diagnosis of pelvic pain. And here are additional resources, including those focused on pelvic pain, those focused on an emerging entity associated with pelvic pain, small fiber neuropathy, and additional resources as well. And we thank you very much for your attention.
Thank you so much, Charles. We have one question, and that is from Marcio Agosto Averbach. He asks if there are any clinical characteristics which we should take into account while considering botulinum toxin injections in the bladder or sacral neuromodulation for patients with chronic pelvic pain. So that's probably more for me, but I do tend to send patients for physical therapy before even contemplating the more fourth line interventions for pain. And one clinical characteristic is making sure that if there is retention, that's not going to be the end of the world for the patient. And I might start very gingerly in a patient with pelvic pain if I'm doing botulinum toxin. So 50 to 100 units rather than 100 to 200 units. And sometimes a bilateral test trial is recommended if we're really trying to drill down on pain. But again, these are all off-label applications, so it's even more favorable if urinary urgency and frequency or the FDA applications for those interventions are present. Charles, I have a question for you.
Sure.
One thing that's really apparent to me, because I see voiding dysfunction, is that the small fiber neuropathy impacts both autonomic dysfunction and somatosensory dysfunction. So whereas chronic pain doesn't really make sense when you first look at it with bladder, bowel, lacrimal duct dysfunction, it really goes hand in hand. And that's why we see many of those patients who just seem to have so many problems.
Yes, you answered your own question. I think when we start asking patients about these other aspects of their lives, that's how we started thinking about this. When you start thinking about all the other things that are going on with them, they kind of come together. And to the extent that the emerging understanding that small fiber neuropathy is highly prevalent in certain groups of individuals with complex pelvic pain, I mean, a large number, really opens this. After all, this is something we just noted within the last year or two, and it really forms the basis for looking forward about how maybe we can design our therapeutic arsenal to address these in a more global way. And I think that, yeah.
I'm seeing a lot of primary bladder neck obstruction in the small fiber patients. And so we'll be going back and documenting that in a way that's more communicable, but that's an important finding I've been observing. How many of the patients you see whom you diagnose with small fiber have seen other neurologists before and the diagnosis has been missed?
Oh, 90%. 90%.
Same with the autonomic dysfunction from my angle.
Right. Yeah. So I think that observation is really important. And now the challenge for all of us is to figure out what to do with it.
Wonderful. Well, we'll look forward to those interventions on the sodium channel.
You bet.
Great. Thank you so much. Nice to see you.
Same here. Bye-bye.
Okay. Bye.